I'll speak on prostate cancer. So I'll be just taking you through the normal anatomy, physiology, and then the signs and symptoms of prostate gland, how to diagnose, and what are the treatment options.
Got it, doctor.
So prostate as a gland, you can see that it's situated just below the bladder in the pelvis. It's a donut-shaped gland, and it encircles the urethra, and it lies between the bladder and the pelvic floor. So, and it's present just in front of the rectum. So it is possible that we will be able to appreciate any size of the prostate by doing a digital rectal examination.
Okay.
And the prostate is divided into 4 zones. It's a central zone which is surrounding the ejaculatory duct. The fibromuscular zone, that's a smooth muscle which is making up around 30% of the prostate mass. And there is a transitional zone, which is the smallest zone surrounding the urethra, and peripheral zone contains 75% of the glandular elements in the prostate. So why we need to know this is because there can be subtle difference between the benign prostatic hyperplasia and the malignancy. So we can see that zone A is the central zone, B is fibromuscular, and C is a transitional zone, D is a peripheral zone. So each zone can have, is made up of epithelium and the stroma. And epithelium, we have the luminal and neuroendocrine cells having a basal layer, then a basement membrane, then followed by the stroma and muscles. So BPH is mostly seen in the central zone, whereas carcinoma is seen in the peripheral zone. And it has 4 surfaces, like posterior, anterior, 2 inferolateral surfaces, and it also has got a base and apex. The gland is more broader than longer, and it weighs approximately 15 to 20 grams. And this is the relationship in anatomy.
Doctor, I think we need to change the slide as well. Like it's on first slide only. I think the next slide you were talking about.
Okay, you're not able to see the thing?
Yeah, now we can see. Previously, we were not able to see.
So actually, I've been running through this.
Okay.
So,
now we can see the second slide. Yeah.
Now, so I will just go through, run the slideshow, but I think you are not able to see the slideshow.
Yeah, we are not able to see.
So now I have gone to the next slide. Is it seen?
Yeah, we are on second slide, which is visible to us.
Then fine. So I think we'll now.
Yeah.
So can I present like this itself?
You can present like this only.
That's fine. I will minimize this as possible, and I'll increase the. Sorry. Okay, this is
the yeah.
Yes. Okay. So this is the bladder and then the prostate, and in the central zone we have the urethra, and then below the prostate we have the levator ani and floor of the pelvis muscles.
Okay.
And this is the entire urethral structure, and from the bladder the urethra passes through the prostate, that's called the prostatic urethra, and then enters the penis, and we have this membranous urethra and urethral meatus up to that. So why we need to know this is urethral prostatic urethra is the widest, and it's the most dilatable part. It can extend up to 3 to 4 centimeter dilations can be happening, and the prostatic duct and ejaculatory ducts open here. So any problems here then can result in difficulty in passing urine. Prostate supply, we can see that the prostate is then closed by a true capsule, which is a thin fibrous sheath, and the false capsule, that's the pelvic fascia. And in between these two capsules, we have the venous plexus, that's called the Batson's plexus. And the blood supply is by the internal iliac artery and its branches of inferior vesicle and middle rectal branches. And the prostatic venous plexus thin wall hemorrhagic risk is more. The Batson's plexus, which connects with the entire spinal cord and goes up to the cerebellum. So brain metastasis, which is having a cerebellar metastasis, you have to think that it can be a prostate malignancy. Coming to the lymphatic drainage, it is mostly the sacral lymphatics, and some internal and external iliac nodes will be the draining nodes for prostate. So, as we all know that prostate is an exocrine gland, and it plays an important role in the male reproductive system. Its main function is to produce and secrete prostate fluid, which is a constituent of a semen. And during our development, we can see that testosterone and dihydrotestosterone are the main hormones which are involved in the growth of a prostate gland. So this testosterone and dihydrotestosterone is from a central stimulation, and it can have a negative feedback system which can control the growth of prostate and the hormones associated with it and the growth of cancer. Prostatic fluid is usually thin, milky, and it's approximately 20 to 30% of the semen's volume. And we can see that the semen, it is around, plasma is 90%, or sperms constitute only 10% of that. And out of the seminal plasma, you can see that 60% is from seminal vesicles and only 30% from prostate glands. And all the acids, cholesterols, clotting enzymes, plasminogen activators, spermine, calcium citrates, all are from the prostate glands. So this is the basic and the physiology. And now when we come to the development and progression of prostate cancer, prostate is a hormone dependent cancer, and it was one of the earliest cancer to have an attribution to hormone dependency, and manipulation of hormone resulted in control of cancer. So this was seen earlier with Huygens. So when cancer treatment development took place, surgery was the main component of oncology management. Then by 1896, we had radiation coming up. And by 1940s, we had chemotherapy coming up. But it was Huygens in 1950s who was interested in the hormones. And when he castrated the sheep, he found out that prostate size came down. So that was how hormone was identified as one of the commonest reason for prostate malignancy. And any manipulation of this androgen resulted in treatment cure. So we can see this is the testosterone production, and it starts from the hypothalamus, and then from hypothalamus we have the LHRH, which goes to the pituitary. Then it produces the LH and prolactins, which can go to the testes and prostate to result in testosterone and dihydrotestosterones. And from pituitary we can have ACTH, which can go to adrenals, and adrenal androgens also can come up. So why this pathway is, we need to know is, it's not sufficient that we remove the testes alone, so that we can be thinking of that testis is removed, androgen is stopped, so that the disease is going to come back, settle down. But the adrenal androgens will be still active and the disease can progress. So that is why after the surgical removal of testes, we still need to give anti-testosterone drugs to control this peripheral androgens. So as we earlier discussed, the majority of prostate cancers begins in the peripheral zone, and it slowly increases in size, and most of them it's in the peripheral zone, but still we can have 10 to 15% in the transitional zone and less than 10% in the central zone. And most of the cancers start off as pre-malignant lesions, including prostate intraepithelial neoplasia, but it's very hard for us to identify this PIN, unlike what we see in CAN, that's a cervical intraepithelial neoplasia, because CAN we have an easy pap smear to do, whereas in PIN it's very difficult. And as we had discussed, androgen signaling is important in the development and maintenance of the prostate cancer. So any removal of androgen production results in the control of disease. So this is the negative feedback mechanisms which we all know from in our UG days. The hypothalamus releasing the LH-RH hormone, and LH-RH causes the pituitary to release the LH, and LH induces the testes and adrenal glands to synthesize testosterone, which we had earlier discussed. And whenever we have a high testosterone levels, that inhibits the release of LH-RH and LH. So this is a negative feedback which we will be making use in our treatment options. So what are the other effects of testosterone? So why we need to know this is when we are going to block the testosterone by anti-androgens, it can also affect the male hormone related problems. That's what we will be experiencing as side effects. So testosterone in kidney produces erythropoietin. In muscle, it increases the muscle mass and strength. In skin, it produces hair and supports collagen production. Bone increases the bone density, bone growth, and production of RBCs. And in brain, it can be responsible for libido and aids in cognition, memory, and feelings. So whenever we are going to have an anti-androgen therapy, we can expect that there can be anemia due to the suppression of erythropoietin, loss in muscle mass and weakness, and decreased in hair growth and skin dryness, and osteoporosis of the bones, and also a decreased libido. So these are all the side effects because we are going to suppress the testosterone. Coming to epidemiology, you can see that prostate cancer is a significant worldwide issue, and in 2020 there was an estimated 1.3 million new cases and 3.75 thousand deaths related to prostate cancer. So one thing which we will be able to appreciate here is, though the numbers are very high, it's only 1 in 4 patients die to a prostate cancer, unlike a CNS tumor or a GI tumor or a lung cancer. So we have a longevity associated with this prostate cancer. So that's why we need to make sure that the prostate cancer can be treated and can have a good quality of life. And in worldwide, the incidence wise, it sees that after lung, prostate is the second most common. But when it comes to deaths, it's below lung, liver, colorectal, and stomach. That is the percentage wise. But when you compare to esophagus or pancreas, you may think that they are more. But only thing is the incidence of prostate cancer is more than what we have in esophagus and pancreas or leukemia. And this is the cancer incidence in India. This is the Global data, 2020 data, and it was around 34,540 cases, ranking among 12th among all cancers in male. And the death was around 16,783 patients. But by 2040, it is expected to nearly double from 1.41 million to 2.24 million. So with the increased incidence and we need to know what are the signs and symptoms of prostate cancer and how to identify them very early and treat accordingly. So most of the patients can have a frequent urination or either a weak or a interrupted urine flow, pain or burning during urination or blood in the urine, the urge to urinate frequently during the night, and different symptoms if the cancer has spread according to the site. If the bones are involved, pain in the back or weight loss, fatigue. But most of these patients will not be having any of these symptoms, or these symptoms can be similar to symptoms of other medical conditions. So this is the reason why in a prostate cancer, nearly 90% of the prostate cancer patient comes to us in a stage 4. Patient will not be having any of these symptoms and maybe a master health checkup which could have picked it up. And only the 10% of the patients will be having this difficulty in urination or bleeding during micturition. But as we see, most prostate cancers present at an early stage, but our clinical practice is that we see them mostly at the elderly and advanced stage. So this is the US data where they will be doing an yearly examinations, frequent medical checkups for insurance purposes, which we don't do it in India. So the symptoms during early stages is very, very rare. But when it is in advanced stages only, we will be able to appreciate all the problems. When the symptoms associated with primary prostate is mainly frequent urination, nocturnal urination, slow or weak flow of urine, blood in urine or semen, and erectile dysfunction, pain during urination, and discomfort or pain caused by the enlarged prostate. So whenever we have a problem, it can be also due to a benign condition or infection like prostatitis. But when it's going to persist for more than 2 weeks, we need to evaluate it very thoroughly. And when it has a local spread like extending to the rectum, then there can be a bowel-related problems like constipation, abdominal or rectal pain, or bleeding can also occur if the tumor spreads locally to the rectum. Again, if the tumor has gone into the prostate and then extended to other parts, it can begin to compress on the spinal cord, which can result in paralysis or a difficulty in emptying the bowel or even anal leakage. So these are the local signs, and these are the symptoms of metastatic prostate cancer. It depends on the site of involvement. It can have a spinal cord compression, resulting in weakness, numbness, or urinary problem, urinary incontinence, difficulty in urinating, or fluid buildup, because there can be a swelling in the leg or stomach because of obstruction of the lymphatics due to involvement of the external or internal iliac lymph nodes. And we can have bowel problems like diarrhea, urgency, fecal incontinence, abdominal pain, flatulence, or constipation. And when it's in bone is the most common site of involvement of prostatic cancer. And it can be having a painful hip, ribs, thigh, and any pathological fracture in an elderly age, we need to rule out a prostatic cancer. So with these signs and symptoms, how to diagnose? So when a patient comes to us and when you have a high suspicion of patient having a cancer, prostate cancer, the simplest test is a PSA test. And in PSA test also we have many things like doing a free PSA and having a PSA to free PSA ratio, PSA velocity. So these are the two things which we need to do. It's not that we do a routine PSA. And if the PSA is increased, then we can do a digital rectal examination and see whether the prostate is enlarged. If there is an enlargement, then we can do a transrectal ultrasound and a guided biopsy. And if the cancer is proved, then we need to image. And nowadays we have an MRI of the pelvis so that we can know the extent of prostate involvement, and also PET scan. And when it comes to PET scan, now we have a specific thing called PSMA PET scan. So that will be giving a good idea of how instead of FDG PET, you can see that this can be better imaging options. So we need to have a very thorough medical history, physical examinations and biomarker testing, imaging, and a biopsy. And when it comes to biopsy, we need to know the Gleason score, that is the grade of cancer, which I will be discussing now. Extent of cancer, because we need to sextant biopsy, that was 6-core biopsy, now it has increased to extent biopsy, 10-core biopsy has to be done, and the location of cancer, and the percentage of cancer in each biopsy. So this all will give us an idea of whether the patient is in a low risk, intermediate risk, or high risk. So this is all what we have done, and this is how we do a digital rectal examination and try to see the prostate. It will be felt as a hard lesion, and which is just below the bladder. And in a benign prostatic hyperplasia, it will be as similar to prostate cancer, but with age we might be able to know that whether it is a BPH or an cancer. So PSA level is the first step, as we have discussed earlier, and we need to measure the levels of PSA. So a total PSA of more than 10 nanograms per ml carries a 67% chance of biopsy detectable prostate cancer. And in addition, we also need to know whether the patient's age is there, because the patient, as the patient gets older, the PSA level also can increase. And we need to know the staging. So the biopsy is the next step. So the biopsy will be either with a transrectal ultrasound, or we can do an MRI guided truss biopsy, or a transperineal ultrasound, of which transrectal ultrasound is being done most probably by all the radiologists, and it's the easiest of all to be done, and most centers sticks to that. And coming to recommendations on when and how to do a biopsy, so we can see that all men above 45 years with the PSA above more than 3 nanograms per ml, and with a suspicious digital rectal examination, or patient aged more than 75 years with a PSA more than 4 nanogram per ml, all should undergo a workup to know whether there is a cancer or a BPH. So we need to repeat PSA at least once in 6 months, and multiparametric MRI. So the multiparametric MRI is where now MRI has come a long way and saying the extent of the disease, and it's a imaging wise itself they'll be able to say whether it is a benign or a malignant lesion. And if any of this is very suspicious, then we need to undergo a biopsy. So once biopsy is confirmed, then we can either do bone scan, CT scan, MRI, X-ray, but of late it has been completely replaced with PSMA PET scan. When situations are there that we cannot afford to do, or there is no possibility to do a PSMA PET scan, then we can stick to a whole body MRI, which can also work up as a staging scan. So this is the grading and staging, and we all follow the TNM classification. T is the tumor. If it is restricted or non-palpable, then it becomes T1, and a palpable tumor confined to the prostate is T2. Palpable tumor beyond prostate is T3, and if a tumor is fixed or invades the adjacent structures, then it's T4. Coming to the nodal site, if N1 which means a single lymph node less than 2 centimeter in dimension. N2 is single or multiple lymph nodes, but none more than 5 centimeter. And N3 is more than 5 centimeter in dimension. And coming to the metastasis, M0 is no evidence of distant mets, or M1 is distant mets present. According to this, and according to a combination of PSA levels, then we can group them. So this is the Tnm staging. It's an elaborate staging, but as all we know that initially it is a localized lesion, and when it has spread beyond or any node, then it becomes stage 4A. So when it comes to node positivity, irrespective of any T and M0, it becomes stage 4A. And if it is a metastatic, then it becomes stage 4B. So that is why we can see that most of the patients, when we see itself, is in the stage 4. They need not have a metastatic cell, but a nodal positivity alone classifies them into a stage 4 disease. So this is how we can see. And the thing is, we need to do a cancer staging. The importance of cancer staging is that it helps us to ascertain the appropriate therapy. Though most of us tend to see that it is the prognosis of the disease, as an oncologist, we always tend to think of the appropriate therapy according to the staging. And the Gleason score is one thing which we need to know. So after a biopsy from all the core, we need to have this. This is 5 groupings where level 1, grade 1 is nearly a normal cellular pattern. Grade 2 is some abnormal cells closely packed. Grade 3 is many abnormal cells within the tissue. Grade 4 is very few normal cells. And grade 5 is completely abnormal cells. So this is how it is. And because the because the biopsy samples may not be uniform throughout, there may be different grades present in one samples, and we have to take the 2 most prominent grade tumors, and the combination of that will be taken as the final Gleason score. So the best possibility is you have 1 plus 1, 2, or extending to 5 plus 5, 10. And first 1 plus 1 or 5 plus 5 or something else, what is the predominant grade which is present? See, suppose we have one, most of the tissue which you have is grade 3. Then we say 3. And the second most common grade is grade 4. Then we say grade 4. So 3 plus 4, 7. The other way also, if it is 4 on the most common thing, it is 4, and 3 on the second side, it is 3. 4 plus 3 is equal to 7. But clinically, 3 plus 4 is equal to 7, and 4 plus 3, 7 are not equal. They behave very differently depending on the predominant grade of Gleason's. So if 4 is the predominant, then the patients behave badly than the predominant patients who have a grade 3. So 7, Gleason 7 is a gray area which you have to be very careful. So with all these clinical states, we can see that it's a patient will be on a continuum of disease parameters. We can see that the primary treatment, once the PSA level increases, then we start them on a primary treatment and then continue on adjuvant treatment. The patient may be very sensitive for so long, or some people may not be very sensitive and then they will come back within a few months. So when they come back, then it is called a biochemical recurrence, and then we need to know the testosterone and PSA level and see whether the patient is still sensitive to hormonal management. That's called hormone sensitive 1. So this time goes on, and then there will be a period when then the patient will have a castrate level of testosterone, but they will not respond to our standard hormonal management. So that is called castrate resistant prostate cancer. So this is when the disease gets very active. They may not respond to our hormone treatment, and then we need to consider systemic treatment with chemotherapy, with radiotherapy, with radionucleotide therapy, or of latest immunotherapy and inhibitors. So this is the continuum of disease, and these are all the treatment probabilities which we can have. So this is most commonly prostate cancer will be dealt with urologist, because they are the primary point when the patient goes to the urologist for difficulty in urination or blood in urination, and then they start with the local therapy, either with androgen deprivation by castration, surgical or medical, and the patient will be put on anti-androgens, and then for a good number of period, the patients will not be having any symptoms, and then it will be referred to oncologist once the PSA levels increases to beyond the normal level. And nowadays, urologists are also happy to deal with first line or second line of metastatic castrate-resistant prostate cancer, and then refer to the oncologist only in the later lines. Once it comes to oncologist care, it is mostly very, very symptomatic metastatic patients and may not be responding very well to the earlier treatment options. So when we come to prostate cancer, we need to have a multidisciplinary team. We need to have an pathologist, radiologist, a urologist, radiation oncologist, medical oncologist, a surgical oncologist for urologist, and also we need to have a good nursing team, clinical genetics and palliative care unit when in the later stage of disease. So the primary treatment is mainly to block the production of androgens. Either it can be done by surgery, architectomy, or by medicines. That's called androgen deprivation therapy, ADT, wherein we use LHRH agonist or antagonist. Either we use straight medicines which suppresses the LHRH production, that's called antagonist, or we give LHRH agonist so that the negative feedback is kept under constant control, so that LHRH doesn't produce other things. And when we have progression of disease, and when this ADT stops working, then we can have either androgen receptor blockers or androgen synthesis inhibitors. So androgen receptor blockers are one which can block the androgens, so that even though we have an androgen in our body, they may not be able to express and put in the stimulation of the cancer cells. And androgen synthesis inhibitors will have more complications than the androgen receptor blockers. So these are all the common drugs which we have. The LHRH agonist, that's most commonly leuprolide and goserelin, and the antagonist is degarelix, which we have, and the most common antifungal agent ketoconazole is also used because it can ablate the adrenals and thereby inhibit the production of androgens from the adrenals. Or we have the androgen receptor antagonist. Most commonly we have the bicalutamide, flutamide and enantamide, which is in combinations with either surgery or GNR channel locks we'll be giving in the primary management. And we have the newer molecules like 5-alpha reductase inhibitors, finasteride, which can also be useful in management. So this, as we have discussed, LHRH agonist and antagonist. And when we start LHRH agonist, the patient can have something called a testosterone flare, because they'll be giving a stimulations, and then pituitary glands results in a temporary surge in the LHRH, which can result in increased body pain or difficulty in urination, and if there is a possibility metastasis to the spine, then there is a possibility of spinal cord compression. To avoid that, we always give a week or 2 weeks of anti-androgens, that's most commonly flutamide or bicalutamide yearly, and then start with LHRH agonist. So these are all the side effects which we have been treating it, I have initially told. So this is androgen blockers. We have androgen synthesis inhibitors with abiraterone, whereas receptor blockers are enzalutamide, apatolamide, flutamide, bicalutamide, and nilutamide. So the best thing is archiectomy, which can result in 90 to 95% of reduction in testosterone in the blood. And this is a radical prostatectomy, which is done by surgery, open surgery, or robotic surgeries. And we also need to do a pelvic lymph node dissection. Or if surgery is not possible in the early stages, we can also use high energy radiation therapies. It can be with external beam radiations, brachytherapy, or also with proton therapies now. And coming to chemotherapy, we have docetaxel and cabazitaxel. And the latest immunotherapy is with pembrolizumab and sipuleucel D. You can see that the prognosis is determined at tumor stage. 5-year survival, stage 1, we expect around 100%. Stage 2 also 100%, but it comes down to 95% when it is stage 3 and around 30% in stage 4 patients. So the numerous factors which can influence the patient's prognosis is age, other comorbids, tumor grade, site of metastasis, and PSA levels. So these are all the prognostic factors, and we need to be very careful. And biochemical recurrence is when we have the increased in PSA levels, and if it is increased more than 2 nanogram per ml above the nadir level, then there is a biochemical recurrence. So we have various combinations of treatment. We will be going with one other line of treatment which has not been previously exposed. So future treatment options, we can see that docetaxel was the only one by 2004, then it increased to cabazitaxel. By 2011, we had abiraterone and enzalutamide, and by 2013, we have the radioactive element radium-223. But now we have PARP inhibitors, immunotherapy, and PSMA lutetium-177 treatment options. So these are all going to enhance the tumor longevity of the patients. And also, we have come to a stage where we can see that the precision medicines are the best. We have a tumor and the patients can have different mutations in them. So these all mutations can be checked up with the tissues and then sending them to something called NGS panel, next generation sequencing panel, where we will be able to detect any number of genes according to the methodology used, and we have even 1,600 genes can be detected in around 21 working days. And though we have many numbers, we are still we don't have much targetable treatment for all the mutations. Right now we have something called homologous recombination repair, HRR, for which we can be giving this something, medicine called PARP inhibitors. Okay, so if the patient has got an HRR mutations, we need to give genetic counseling for the patient's siblings, sons and daughters. Thank you. I'll be happy to take questions.
Okay. Guys, to ask questions, whatever doubts you have.
Sir, I have one doubt, sir. Sir, is it okay to for the males above 45 years to get the PSA test done? Because in the early stages it's not detected.
No, I'm not able to get the last one. Above 45 years to take the
PSA testing done, because as you told that in the early stages it is not asymptomatic and it is not detected. So is there any males can take the test on a regular basis?
Yes. You can always have that done, because PSA is always easy. It's a blood test. When you have an a regular master health checkup done. It's easy that you do it. And once you have age-related PSA level, see, less than 50 years, your PSA level should be less than 3. Above 50 to 60, should be less than 4. Above 60, less than 5. So anything which is increasing above that, then you need to put in the next PSA to free PSA. That will give you the probability of whether it is a benign lesion or a malignant lesion. So you can always do that, and as similar to an mammogram or pap smear, which has to be done yearly, PSA level testing also can be done yearly.
Okay. And doctor, how do we differentiate between whether it is a BPH or a metastatic, this thing? Like if only on the basis of PSA, suppose if PSA is above 10 nanogram, then only like...
We need to do a free PSA, and if the ratio is more, then the chances of malignancy is more.
Okay.
Then we have this MRI scans now.
Okay.
So we have the volumetric data now, and the imaging has gone to a very big extent that they are able to given all the 10 cores, the segment anatomy which I had said, each and everything, whether they are turning to a malignant or it's a BPH. But once you have that, it has to be always confirmed with the biopsy.
Also, if you can put some light on like surgery, the surgery cost, the stay in the hospital, chemotherapies, and how many chemotherapies are required for the patient, because we do get many patients for this.
Yeah. So surgery, it depends on whether it's going to be an open surgery or a robotic surgery. I'm not a surgeon, so I don't know the cost. A simple guidelines is nowadays we don't do an open surgery. Very, very difficult. And robotic surgery is coming up, especially in Chennai. We have some centers. And the advantage of robotic surgery is your stay is only 2 days. You get discharged on the 3rd day. Cost, I don't know, frankly. And I'm another specialist. I'm a radiation oncologist and a medical oncologist. So I can throw some light on the radiation. So if the patient is not fit for or willing for surgery, we can have radiation. Radiation, something called, we have rapid arc treatment. That might be around 3 to 3.5 lakhs for the entire session. But if it's going to be a proton therapy, it can be around 40 lakhs.
Okay.
And chemotherapy, it's a package. The entire sessions around 30 days of treatment.
Okay.
And if it's going to be chemotherapy, IV chemotherapy with the docetaxel or cabazitaxel will be done only in patients less than 65 years of age. And above that, we will be always restricting ourselves to hormone management. So chemotherapy will be around 20,000 each sitting, once every 3 weeks for 6 sittings. And coming to hormone tablets, it can be around 10 to 15,000 per month.
Okay, got it. Guys, do you have any more questions?
Yeah. Hi, sir. Sir, can stage 4 can be treated by cyberknife?
No. So, see, you can treat stage 4 with cyberknife, but you need to know what are the indications which cyberknife can treat. See, suppose you have a brain metastasis or a bone metastasis, and which is less than 4 into 4 centimeter, and that is the only site of metastasis. Then you can treat it with cyberknife. So a metastatic site more than 4 into 4, it cannot be treated with cyberknife.
Okay.
And when you have more than one site of metastasis, there is no point in treating them with cyberknife.
So what is the most common age factor for this prostate cancer, you think?
Most commonly we see above 60 years.
I have a question. Can also be a sign of prostate cancer.
Which one? Which is?
Pain. If some patients like complains for pain in genitals.
Yes, you can have pain during maturation or pain post sexual activity. It can be there, but also you need to know that there can be a prostatitis, inflammation of the prostate also can be there. So a better thing is you always do a serum PSA with a free PSA, put them on antibiotics for 2 weeks. If that doesn't settle, investigate further.
Okay.
Sir, are
So
there
what are the chances that the cancer could have spread beyond the prostate? Like, what are the usual chances that cancer usually spreads beyond the prostate?
Now you are asking me what are the chances, right? See, most probably prostate cancer is a slow growing disease, and it's only 10% of the patient comes to us in the earliest stage. 90% of them comes to us in the advanced stage. In advanced stage, I have been saying that even a node positivity, it need not be a bone spread also. Bone is the most common site of spread from prostate cancer. But in our clinical practice, we see that 90% of the patients comes to us with prostate metastatic, and it's only the bony pain which has brought them as, rather than the problem due to prostate.
okay? So,
Are there any?
are there
What
any?
is the range of, let's say, below 45 years of age?
Correct? I'm not able to get you.
If a patient is between like below 45 years of age, so what will be the PSA value?
No, it's less than 3. Less than
Less than
3 for 50 years, less than 50 years.
So also very common question that we get to from the people who are younger than like 45 years of age and are suspected with prostate cancer or are detected with prostate cancer. What are the chances of them getting children after the treatment?
You need to know about the prostate cancer or the cancer patients as such.
No, prostate cancer. The patient who are younger in age and are suspected to prostate cancer or have been detected by prostate cancer, but they usually come up with this question that if I go for the treatment, like chemotherapy, so would I be able to have children later on?
Now, if I go for the treatment, and I am not able to get your question.
So what I'm trying to say is, like, if a person is younger in age and he is suspected or been diagnosed with prostate cancer, so he usually asks this question that if I go for chemotherapy for the treatment or the hormonal therapy, so should I be like after my treatment is completed, will I be able to get will I be able to have children?
No. So that is a problem with males and females. That is because of the basic designs of male and female. So sperms produces each and every day. Okay, whereas egg females will have a certain amount of egg. When they have a menarche by 12 or 14 years, they have only 400 eggs, which comes monthly. And even if they give chemo, there will be a temporary stoppage of the periods, and then after some period, some months or years, they'll regain their periods, and then they can have children. But that doesn't happen with males. If you give chemotherapy, they are going to be sterile. They may not be impotent, they'll be sterile. So it's very hard for them to get a child thereafter.
So what could be the other possible side effects of radiation therapy?
The side effects of radiation, you will have skin blackening, skin peeling, and because prostate is near to rectum and bladder, you might have painful urination and painful stools and frequent stools with a liquid consistency, something called as tenesmus. But whatever complications with radiations, it's going to be temporary. 6 to 8 weeks post radiations, everything is going to come to a normal level.
Okay, sir.
Shrutika was asking something, so others.
Yeah, sir, I was asking, are there any complications that may arise during the treatment, or how frequent are the complications?
What complications, either due to treatment or due to the disease?
Due to the treatment.
Due to the treatment, right? So as I have been saying, Dr. Meenakshi was asking about radiation, which can be the complications. Because of surgery, prostate, you can have pain, and the machine which goes through that, even if it's going to be a robotic, the entire pelvis gets dislodged. So that can have a very pain. Then there can be a painful urination. So that's with the surgery. Coming to chemotherapy, you have a hair loss, loss of appetite, loss of weight, and all this, and these are all temporary. Once you stop the chemotherapy, this is going to reverse back. And as I have been discussing in the treatment during the presentations, when you are going to give anti-androgens, they act as a female hormones. Your male hormones are suppressed, so it becomes like a female. So you can have loss of libido, loss of hair, you can have gynecomastia, you can have fluid overload. So all the symptoms can be there. Symptoms, something like a postmenopausal or a perimenopausal like features can also be there with hormone treatment.
So, sir, due to complications, are there any chance of readmissions or how?
There can be chances of readmissions, but that can be easily managed. That may not be a life-threatening one.
Thank you so much.
And sir, in remission, what are the tests that needs to be done for follow-up and how frequently they need to be done once the patient is in remission?
Pardon?
Once the patient is in remission, what are the tests that needs to be done for the follow-up and how frequently they need to be done?
So once the patient is in remission, it always it's in stage 1, stage 2, stage 3 is where we have a definitive treatment. You do a surgery or do a castration and put them on hormone, and then maintain them with a monthly PSA for the first year or once in 3 months for the subsequent years. But when you diagnose a patient with stage 4, there is nothing called remission. All stage 4 patients has to continue treatment for their lifetime. It can be manipulations of drugs, or stage 4 patients always are going to fail at some point of time, and we need other lines of treatment. So remission is always in stage 1 and 2, 3. That's all.
Sir, I have a question, sir. This is regarding the treatment. Where are there any options for neoadjuvant radiation therapy for people who cannot tolerate chemotherapy, since chemotherapy has a lot of side effects for locally advanced cancers?
No. See, now we need to know one word. What is neoadjuvant? Neoadjuvant is a treatment which is given before the definitive line of management. Here, if you are going to say the definitive line of management is surgery, then neoadjuvant is there. Chemotherapy doesn't come into play. So, radiotherapy or surgery is always in stage 1 and 2 only in prostate cancer. If the stage is 3 or 4, there is no role for radiation as a curative one. It can be as a palliative one. So it can be given for bone metastasis, brain metastasis, or to decrease the size of prostate. But there is nothing like you give a radiation then follow up with chemotherapy.
Yes, sir. So, like what I was asking is, since chemotherapy is not tolerated, a neoadjuvant, I mean to say radiation options.
Radiation? No. If it's going to be a limited stage, stage 1, 2, or 3, radiation can come in play. In stage 4, you don't have an option of radiation as a treatment option. It has to be only chemotherapy.
And also one more question, sir. Regarding the lower abdominal symptoms, sir, considering PSA levels are to be normal, do we suggest PSMA PET also that there might be chances?
No. Whenever we have an PSA increased or a biopsy proven prostate cancer, only then we ask for a PSMA. It is not that we do a PSMA and establish the diagnosis. PET scans are always done post confirmation of the disease to do the staging.
If the primary is a different one, sir, for metastasis of prostate, do we take a PSMA?
No, I'm not able to get a primary of different origin. What
different do you mean? Or suppose if it is a rectal cancer that is spread to prostate, do we take a PSMA for that?
No. There we do something called FDG PET, fluorodeoxyglucose PET. Only if it's going to be a prostate which has spread, then we have prostate specific metabolic activity PSMA PET scan. If it is something else, then it has to be FDG PET. And you can also have something called a neuroendocrine tumor. So one of those slides which I showed had a neuroendocrine cell. So PSMA prostate also can have a neuroendocrine tumor. It doesn't need to be always adenocarcinoma. In case it's going to be a neuroendocrine tumor of the prostate, then we need to do something called DOTA PET scan.
And so what are the conditions under which PSMA is not recommended? Like you said, in some conditions it is not suggested.
Just repeat the question.
So you mentioned earlier that under some situations or conditions PSMA is not suggested. What are those conditions?
No. PSMA is done only in prostate adenocarcinoma. All others we need to do according to the specific disease conditions.
So what are the chances of reoccurrence?
Chances of reoccurrence.
Yeah.
So reoccurrence always comes in stage 1, 2, 3 only. In stage 4 it has always to be continued and they are going to progress. So as we said, stage 1 and stage 2, the 5-year survival is 100%. And stage 3, 5-year survival is 95%, which means 5% of the patients are going to have recurrences. Unfortunately, in India, 90% of the prostate cancer patient comes to it with stage 4 upfront. So that's why it means they are on treatment or they are progressing even during treatment. So there is no point of recurrence. Recurrence comes only in stage 1 and stage 2, stage 3.
So then after surgery, is it always necessary that patient has to go for hormonal therapy or chemotherapy?
After surgery is radical prostatectomy, right?
Yes, sir.
There is no role for that. Once we do a radical prostatectomy, which means the patient is in stage 1 and 2, there is no role for hormonal treatment or chemotherapy. But if the patient recurs, then you need to manipulate according to it.
And so what is the survival rate for prostate cancer patients?
So as we said, the stage 1, 2, 3, they have a very good 5-year survival. If stage 4, it is around 30% of 5-year survival.
Sir, if someone is detected with prostate cancer in very early stage, as you described that the concern will be the fertility rate will be affected by that. So can we suggest that those patients for fertility treatment like egg freezing or something or sperm freezing, like we suggest for female patients?
No. See, most of the patients would have been in the age group of more than 60, which means they would have completed their family life and most of them would have had their grandchildren. And in India, I don't suppose that unlike in abroad, they will be happy to beget a child at the age of 60 plus. So frankly, we don't tell them to have a sperm preservations or something until the patient themselves comes up with the idea, because 60 plus, their lifespan is going to be 10 plus years only. They may not be able to raise a child, and we should be very careful in advising them also. What if they leave a child behind 10 years and who is going to take care of them? Whatever questions you asked is fine, but rationally thinking, we have to be like this. And fertility preservation is also in females less than 45 years only, no? It's not beyond 45. In males, prostate mostly comes above 60 years.
Okay.
Fine.
I think we are done with the questions, doctor. Thank you so much. This was a very interactive session. So, yeah, thanks a lot.
Thank you for the patient listening. Thank you.